Thank you very much, colleagues. Good afternoon, and welcome to our webinar today, where we'll be taking colleagues through a presentation talking about the frontline talk. We call it the frontline talk, where we talk about the National Survey of South African Healthcare Workers' Response to COVID. My name is Professor Kangelani Zuma. I will be chairing the webinar today. I'm a divisional executive at the Human Sciences Research Council in the division called Human and Social Capabilities. I'm very excited, to have this opportunity where, we'll be talking to you colleagues about the pandemic that we're all facing globally. Just by way of, introduction and giving colleagues the process that we're going to take going forward, we've got our presenters that I will introduce momentarily, and then also we'll have our colleagues who are discussants representing a number of institutions, Edendale Hospital, Durban University of Technology, the Health Professions Council of South Africa, National Department of Health, the South African Nursing Council, Democratic Nursing Organization of South Africa, as well as South African Pharmacy Council. So I will introduce all my colleagues momentarily, but just by way of introduction, colleagues, just to brief colleagues why we are here. We are here because of the epidemic that we face. We have organized as the institutions, Human Sciences Research Council, as well as UKZN, we have organized a survey that looks at the issues that are affecting healthcare workers as, as people who are in the front line of this epidemic. Now, in order to assist the government and society to prepare for and mitigate the effects of the spreading of COVID-19 epidemic in South Africa, the HSRC has undertaken social behavioral research consisting of 5 rapid assessments under the auspices of the Department of Science and Innovation. The extensive body of work consists of Wave 1, which was the pre-lockdown survey that was implemented, Wave 2, which was a lockdown survey, the healthcare worker survey conducted in partnership with the UKZN, and also the 2 youth surveys. So the healthcare worker survey is the one that we'll be talking about today. Now, the aim of these surveys have been to gather information to provide insights into the human condition in the time of the COVID-19 epidemic in South African population. Just by way of summarizing what these studies that have been organized to bring them into context, the first survey was organized that looked at knowledge, attitude, perception about COVID-19 among South Africans. And this was the first survey that was conducted in first month of the outbreak prior to announcement of the lockdown. The survey focused on the following themes, that is the knowledge about COVID-19, risk perception, attitude towards COVID-19, and sources of information and communication around the epidemic. This survey also included a rapid qualitative assessment which was conducted remotely with 61 key informants from different social, cultural, and economic background residents in Gauteng, KwaZulu-Natal, and Western Cape. Data from this survey revealed how the 21-day stay-at-home lockdown exacerbated social inequalities for the poor and disenfranchised with the outbreak of COVID-19 pandemic. Fear of infection and food and income insecurity were found to be common across the informant interviews. Despite the social and economic distress, the data also points to the strong narrative of social responsibility. The second survey was about experiences and the social impact of level 5 lockdown among South Africans. And this was as the second survey in these waves of surveys that was conducted during the first 2 weeks of lockdown in the country. So that's when we were at the peak of a lockdown level 5. The survey focused on preparedness for lockdown and quarantine, the economic impact of lockdown, as well as family experiences of food security during the lockdown. The survey also looked at evaluating the adherence of the lockdown regulations. Now, today we'll be talking about the South African healthcare workers' experiences in dealing with COVID-19. So this survey formed in the third survey that was conducted during April 2020, targeted all frontline workers in the country and targeted all categories of healthcare workers in both public and also private sector. There are also two more surveys that are currently in the field as we speak right now. One of them is, which is currently underway, aims to explore the experiences and perspectives of young people in tertiary institutions, including universities, TVET colleges, and other institutions of higher learning. This survey focused on the impact of the closure of institutions, financial challenges, as well as the e-learning and the disruptions of academic care due to the outbreak of COVID-19. The last one, which is also in the field, is the one that the study that is also currently in the field looks at the experiences and perspectives of young people not in education, employment, or training institutions, and how the outbreak and subsequent lockdown impacted on their employment and training prospects, as well as broader economic inclusion issues. So colleagues, the results from Survey 1 and Survey 2 have been released and publicized. The data from these two surveys have provided the evidence used by the state to support the tobacco ban, as well as the provision of key messages related to socio-economic behavioral interventions and used by the Minister of Higher Education to provide insights to the National Command Center. Now, colleagues, it is now my pleasure to introduce my two colleagues who will be presenting providing the presentation. Professor Priscilla Reddy, who will provide detailed background and also the methodology. Professor Musa Moshabelo, who will be presenting the recommendations. Before they present, just to give an overview of our esteemed presenters today. Professor Reddy is a social behavioral and health promotion research scientist, currently leading the public experience research response of the public to COVID-19 on behalf of the South African Human Sciences Research Council. Outcomes from these large studies that she has been leading have guided the national government leadership response to strategy and policy formulation. Ongoing studies continue to inform the response as the country's infection trajectory continues to present the nation with a myriad of complex decisions. She has published widely in peer-reviewed journals, served on editorial boards and policy think tanks. Her work in the African region spans more than 26 years, focusing on critical public health interventions like smoking cessation programs, youth and risk behavior reduction, HIV and AIDS and related rights and health issues, ensuring that her research reflects the need of the environment within which she operates. She has promoted 15 PhD graduates through Maastricht University, these academics who now provide much needed research expertise to the African public health sector. And also introducing Professor Musa Moshabelo, who holds the position of Associate Professor and Dean in the School of Nursing and Public Health at the University of KwaZulu-Natal. He is a chief medical specialist who trained as a medical practitioner and specialized in family medicine and primary health care, which adopts a biopsychosocial perspective of health. He further completed a master's in demography and health, and his doctoral studies were done in the field of public health with the specific focus on health systems and policy research. He has received focused training in the practice of HIV medicine, a public health priority area in South Africa, and has also engaged in tuberculosis and more recently on drug-resistant tuberculosis. He is currently an adjunct faculty and Wellcome Trust Research Fellow at the Africa Health Research Institute in South Africa. His research portfolio in implementation science and health system research cuts across multiple disciplines and involves the design, implementation, and evaluation of complex interventions in public health services and programs, and seeks to improve access, quality, and equality in healthcare in ways appropriate for resource-poor settings in sub-Saharan Africa. Professor Moshabelo is currently the convener of the COVID-19 response team at the University of KwaZulu-Natal and a member of the Department of Health War Room for COVID-19 in the province. So these are our two colleagues that will be giving us the presentation. Now, I just want to urge before they start presenting, just to inform our participants that if they have questions that they would like to ask, if they could please use the question and answer session so that their questions could be attended to, and will, at the end, after our discussants have given their response, we will take those questions accordingly. Over to you, Prof. Reddy and Professor Moshabelo.
Thank you for the introductions, and also thank you to the university for hosting this webinar so we can share our data and our findings with a broad fringe of colleagues, and after this, hopefully with more South Africans. So I think you've explained the background sufficiently, safe for me to say that we've entitled this presentation today, Frontline Talk, South African Healthcare Workers Response to COVID-19 Pandemic. And this is part of our Asikuluma set of research studies that we've done. So by way of context and background, as we all know that when the HSRC started these studies, there weren't many, if any, study tools available at all. So what we had to do was to go back to the drawing board and to look at what's available and how do we frame our research. So for the health worker study in particular, I take you back to 2013 when there was a conference held in Brazil to discuss human resources in order to renew commitments to universal health coverage. Subsequently, a report was commissioned by the WHO and others to assess globally what would contribute to a fit-for-purpose health force, a fit-for-purpose and practice health workforce. And from all of these reports and discussions, what emerged was one universal truth, and that truth was that there would be no health without a fit-for-purpose and practice health workforce. That was 7 years ago in 2013. More recently, I draw your attention to the State of the World's Nursing Report, and I quote from the head of the WHO, "Nurses are the backbone to the healthcare system. Today, many nurses find themselves on the front line in a difficult situation. This report is a stark reminder of the unique role they play and the fact that they need support in order to keep the world healthy." Why am I quoting from this report? The reason is, if we look at the South African health workforce, the data that's available to us tell us that at least 65% of this workforce is made up of nurses. And this being Women's Month, what we also know is that the majority of the nurses, from the data I've looked at, are women in South Africa, a time to be celebrated. Globally, at the time of conducting this study, at the time of conducting this survey, when we looked at the WHO data, at that time, we found that there were about 90,000 healthcare workers infected with COVID-19. And at that time, the time of conducting the survey, there were 600 deaths that had been recorded. Now, if we look to the current day affairs in South Africa, what we see, according to the Minister of Health, and I'm quoting from the 5th of August, is that there were approximately 24,000 healthcare workers who were diagnosed with COVID in South Africa, with 181 deaths recorded. And this is directly from the Minister's statistics. We also note that labor organizations have called for stringent measures to protect healthcare workers. And they've called for things like infection control, namely personal protective equipment, safe transport for those who use public transport, regular screening of healthcare workers by way of COVID tests, and in particular, the provision of counseling services to assist those with mental health issues that emerge during this while they're doing this rather stressful job. I'm going to talk very briefly, as we have a lot of data to share about the study methodology, and we would be happy to engage people outside of this forum to talk more about the methodology. We studied healthcare workers who were 18 years and older from all 9 provinces in South Africa. The survey was conducted at the outset of the epidemic between April 11 and May 7, 2020. Ethical approval was obtained from our ethics committee at the HSRC. And we invited healthcare workers to participate in the study through the website that's indicated there at the bottom. What we learned very quickly is that we had to work very, very hard in recruiting healthcare workers. It wasn't as simple as we thought it would have been. So we had to engage in a multi-pronged strategy using various forms of media and social media platforms. So we used radio, television. We also used other social media platforms. In addition to all of this, we had regular postings on Facebook and Twitter. And what we noticed was that there was an escalation from about, we had bigger numbers after we engaged people on social media. Partners and organizations within the healthcare sector assisted us to also amplify these posts so we could recruit the numbers that we did. Partnerships was one of the most important activities that we were engaged in, and you can see for yourself. And many of those partners are among the discussants today, from academic partnerships to the nursing councils, to the health professional councils, and we received support. And essentially, everybody was keen to ensure that as many healthcare workers participated in this study as possible. This slide just shows where we were when we started the study. On the 11th of April, we had about 2,003 cases, and we just had about 69 people reporting daily. By the 7th of May, when the study was closed officially, we had almost 8,000 people with 236. So we know that we started off well, and then it just escalated logarithmically. And I'm not going to talk about current day statistics. Those are available all over. Okay, so importantly, how did we do this survey? All our surveys follow a strong theoretical background. And what we tried to do is we tried to assess the behaviors, because as we know, with this epidemic right now, there are no pharmaceuticals or vaccines available. So the interventions are public health interventions, which are largely socio-behavioral interventions. So similarly, among healthcare workers, we looked for their demographics, their knowledge about COVID, sources and information about COVID-19, and you'll see how important this is as we share the data, self-perceived risk, including risk factors that are reported, infection prevention and control, not just PPE, personal protective equipment as well, the risks to and concern for family members, as many of the staff go home to their families in the evening. There were a lot of issues around this. And then we looked at psychological distress as well as general health and well-being. These were the themes that were studied via 45 closed-ended questions. The data analysis, as indicated, the data was collected on an online platform. It had to be exported through an Excel process and then into Stata 15.1 with the analysts together from UKZN as well as HSRC. All the data was tabulated with the 95% confidence interval and p-values. We also did a process of where we benchmarked the data and weighted the data according to the distribution of healthcare workers by age, sex, and population group and province. And we did this in order, and this was quite a technique and quite a mechanism. Prof. Zuma, the chairperson, is the lead statistician or the chief statistician, and he guided us really, really carefully with a huge team of analysts from HSRC on how to do this to ensure better generalizability and national representation. And it's my understanding that it's probably the first survey of this nature with or without COVID that has been done in the country. To our knowledge, there were no freely existing databases on the total number of healthcare professionals in that population. So we needed to look at where we could find these databases and sources in order to do that. So we got them through the total number of registered healthcare professionals, thanks to the HPCSA, who's also here today, by province, by age, by sex, total number of registered nurses from the South African Nursing Council, by age, by sex, by province. We also sought some assistance from Stats SA. I will now hand over for the presentation of the results to Professor Moshibela, my colleague who worked with us on the study.
Thank you so much, Prof. Good afternoon, colleagues. So I'll be sharing the results, and just to start off by saying that the total number of participants that we managed to recruit was 7,607 healthcare professionals. We had in the study included medical students, but we have excluded them from this analysis. We had also included health support staff, but we have also excluded those from this analysis. For this analysis, we're focusing purely on the healthcare professionals. So in terms of the distribution of healthcare workers by age, you can see that majority of them were below 50, with a sizable number more than 60 years. And this is, of course, very relevant to COVID-19. And also you can see that majority were female and also Black African. Now, in terms of the provincial distribution, most of them, of course, were in Gauteng, KwaZulu-Natal, and Western Cape. And you will note that the top 4 provinces with the most participants were also the top 4 provinces that were affected mostly by COVID-19. On the other hand, most of the participants were in the urban formal, and this may be likely due to the way we recruited, because most of our participants were recruited through the online survey. In fact, all of them participated through the online survey, but they were recruited mainly through the health professions associations and councils that they are registered with. So we have a reasonable representation of rural areas if you consider the commercial farm and informal and remote rural. But otherwise, it would be important in the future to think about how to diversify recruitment processes in order to capture a larger group of non-urban formal participants, just for noting there. Now, our analysis, of course, today also focuses on the professional category. For this purposes of this analysis, we would group them into 3 categories: the medical practitioner, the nurse practitioner, and other healthcare professional. I want to state at this point that we acknowledge how sensitive it is the way the identity of health professionals is allocated as we learned through the process of conducting this study. And also to make sure that we avoid labeling such as allied. There were people who were very clear with us that we need to be really careful to make sure that we don't call healthcare professionals allied, especially those that are registered under the HPCSA. But also when we say other healthcare professionals, please note that there is quite a huge diversity of healthcare professionals ranging from pharmacists, occupational therapists, radiographers, and social services and so forth that were included or that participated in this study. We have not, for the purpose of this analysis, analyzed the specific categories there, but would focus on what we consider the main key, and this is based on our bias, and we apologize if this is inconvenient for anyone. But just to note that we recognize that there's a large diversity of participants in this study. Also to note that we did not only include participants in the public sector. 50% of participants came from the public sector, a good third came from the private sector, and this is really important for us. And in terms of other sectors, we're including participants from healthcare professionals from the academic sector, NGO, or civil sector. And just to also note that there is a sizable group of participants that are working in both public and private. So the first thematic area that we would look at is that of knowledge. And let's try to see how we can break it down for you. Knowledge is important in terms of the way that it determines behavior and practice. And when we asked this question early on in the pandemic, what our healthcare professionals understood by the incubation period, you can see that majority of them said 2 to 14 days. Now, at this point, it sounds like a silly question, but as you can see that there were quite a number of participants who also included other days. We would have expected at that time of the study, because then the pandemic was already underway, that the understanding that the incubation period is 2 to 14 days would be close to 100%. This is important to note. Again, also in terms of transmission, this was an interesting question. It's clear for everyone that, especially the nurse practitioners, that contact with contaminated services is a form of transmission. But what was really interesting was that at the time, people also thought that there were other modes of transmission, including fecal-oral transmission. The airborne transmission is very interesting because we went from there's no airborne transmission, possible airborne transmission, no airborne transmission, back to airborne transmission. Now, this for me, I want to highlight because of the dynamic nature of changing information. And as you will see later on in our recommendation, is that there needs to be a process of making sure that this is communicated clearly. But a sizable number of participants across the different professional categories recognized that there is airborne role in terms of concerns, especially around aerosolized surfaces, droplets. Now, again here, we're looking at the symptoms. You'll see that obviously the skin rash is an incorrect answer. But at the time, according to the NICD, we were clear that the main symptoms were cough, sore throat, fever, but here we had included headache and runny nose. Now, it's interesting to us that a lot of participants included these categories. At that stage, we would not have expected many of our healthcare professionals to include headache and runny nose. But at this point, we wouldn't necessarily see anything wrong with this, but we would have expected them to focus on the main symptoms. Now, these areas of knowledge are important in terms of assessing the preparedness of our healthcare professionals at this point. Now, the issue of confidence is also important. You will see here that 54.7% of medical practitioners demonstrated confidence in their knowledge, whereas the lowest percentage you're seeing it among nurse practitioners. And you can see those that they did not have confidence in their knowledge is quite high for nurse practitioners. Please note this thematic area around, this observation around nurse practitioners as we go through the study, because it's going to be something that runs through as a thread in terms of nurse practitioners not having adequate preparedness based on this assessment, this survey. Now, we're looking now at sources of information, and you'll see that in terms of sources of information, overall, most of our healthcare practitioners, professionals, got their information from the National Department of Health, as well as official websites like the WHO and CDC. However, it is also important to note that there were news websites and scientific journals and social media and WhatsApp as considerable contributors in terms of access to knowledge. Now, this was a surprise for us, even though it made sense when we started to look at the trends in terms of social media, as well as the way that other sources of information are used. Note that a lot of people who are in the urban areas would lean more towards using scientific journals and official websites as well, slightly opposed to rural areas. But across the board, we did not really see statistically significant differences between the categories. Likewise, by professional category, you will see that across the board, healthcare professionals use the National Department of Health as a source. But it was interesting that it was not more than 70%. There was still a good chunk of about a third of healthcare professionals who were not necessarily relying on the Department of Health as the main source of information. Please note that when it comes to scientific journals, for example, it was mainly the medical practitioners that were using those sources. When you look at other healthcare professionals and nurse practitioners, please note that they were using mostly news websites. Now, this is an important finding in terms of news websites emerging as an important contributor or source of information for healthcare professionals, and it needs attention to be paid to it. The next part is training. Once you've got information, then we assess the training that was put in. The different areas of instruction that we would look at for healthcare professionals, you will see they range from infection control to include screening, isolation, referrals, case definition, treatment guidelines, and declaring patients as recovered. Across the board, you will see that overall, most healthcare professionals were trained in what they call workplace infection control, up to 73% nearly. But the lowest one was around declaring patients as recovered. And you will see that this is a dynamic area that kept changing as guidelines were adapted over time. Similar to treatment guidelines as well. This was an area that only 50% felt that they were adequately trained in. We would have hoped that at the time of the survey that most healthcare workers are also, again, close to 100% in terms of training around case definitions, treatment guidelines, and so forth. Once again here, you would see that there were differences between the professional categories. Across the board, you will see that medical practitioners were the ones that received training in these different areas. Their levels would range from 70% to 80%. And likewise, you will see that for nurses and other healthcare professionals, their percentages were lower across the board. But you will see that especially when it comes to things like declaring patients as recovered or treatment guidelines, case definitions, these were not even more than 50% for the other healthcare professionals and including nurses. Now, one could argue that perhaps there's reason for doctors to receive the training, but we want to make an argument that all healthcare professionals would need to receive the training in these different areas, but appropriate to their professional groups. So there is no reason for us to basically assume that we should see this big gap between medical practitioners and nurse practitioners in terms of the scope of training. So again, in terms, when people have information and they've been trained, this contributes to their confidence in terms of knowledge. Now, you will see that across the different professional categories, generally, the confidence levels were only going up to about 50%. We would have hoped that at the time that we did this survey, because the pandemic was already underway, that there are high levels of confidence among healthcare professionals. But you can see here that we don't necessarily see that. And of course, the contributors to this training would include to this confidence would include the training. And the different areas, of course, were across the board similar in terms of levels of confidence. Now, risk perception is the perception that healthcare workers would have in terms of the risk of contracting COVID-19. You will see that, surprisingly, the provinces that in this country had the highest burden, like the Western Cape and Gauteng, had relatively lower perceptions of risk among healthcare professionals compared to other provinces like Free State and Northwest. Now, this may reflect the urban location of many of the healthcare professionals who would basically have access to information and support and so forth and infrastructure, as opposed to other provinces. But it may also be a reflection of the trust in the healthcare system that the health professionals are working on. But there were differences that were interesting to us to observe in this survey. Again, here you can see that these differences of risk perception can differ for urban formal versus rural. I mean, in the urban formal, it's about 50% in terms of high risk perception and up to 72% in the rural areas, which means that healthcare workers working in the more rural areas felt that they were much more at risk of contracting COVID-19 than the more urban ones. Now, by professional category, this was a key finding on our part. You will note here that the nurse practitioners had the highest level of risk perception, followed by the medical practitioners and followed by other healthcare professionals, which makes sense. But the risk perception, of course, here amongst nurses, we cannot necessarily say that it is not related to the fact that they also received relatively limited attention compared to medical practitioners in terms of training, and also that their knowledge was relatively lower than those of medical practitioners. Now, we know that from literature that already, if your knowledge is low and your confidence is low, your risk perception will be increased. But this is the pattern that we observed from the findings. You'll also see that for those that are confident in their knowledge, they have relatively less risk perception compared to those that are not confident. You can see amongst those that are not confident, their risk perception went up to 72%. Now, this of course supports the hypothesis that equipping people with knowledge, with training, helps in helping to boost their confidence. And when you boost their confidence, then it also helps in reducing their risk perception and ways of them protecting themselves. And you'll see this repeatedly as we move forward. In terms of the different areas that people considered to constitute risk, the highest, of course, had to do with the fact that they are working as a healthcare worker. And initially, when the pandemic started, we did not recognize working as a health worker as a risk factor. But as data emerged from China and other countries, being a health worker increasingly became a tangible risk factor to take into account. Now, also in terms of the behavior of the public, availability of PPE, exposure in the work environment, underlying conditions and risk, and so forth. Now, you'll also see, just to highlight here, that the risk also was similar when you look at the high to moderate and low risk, depending on these areas. The main thing that people are often interested in is the issue of personal protective equipment. And I would like to highlight these areas in this presentation. Of course, many of our interpretations around this data are linked to the guidelines that we have from the Department of Health around COVID-19 in terms of what is acceptable practice and what type of PPE is used under what condition. You will see here in terms of the kind of PPE that was required, almost over 80% across the board, healthcare workers, healthcare professionals identified different types of PPE required. But as part of that process, they wanted to make sure that there is infrastructure for triaging patients, infrastructure to debrief and counseling, and infrastructure for social distancing, environmental controls like ventilation, and so forth. And these things, oftentimes when we're talking about infection control and PPE, we don't talk about these things. We often just talk about the actual attire itself of goggles and gloves. But these other areas also play an important role in limiting infection and the passing on infection between patients and healthcare workers and between healthcare professionals. Just to use one tracer here, I cannot really dwell too much on the detail here. The issue is that, and this is important, that you do not necessarily have to use, so let me put it this way. Each PPE item is used for a certain type of procedure according to the guidelines. So for example, the N95 mask is not something that you would use when you are triaging general patients. You would use a normal medical mask, but up to close to 40%, 2 in 5 of our professionals wanted to use the N95 mask. That is overkill in one respect. On the other hand, you would expect that when you are doing aerosol generating procedures or working in critical care, you have an N95 mask. But then there were some healthcare professionals who felt that you can still use a surgical mask in that area. This is important that healthcare workers are clear about what PPE to use under what conditions. And again here, I want you to notice one pattern. The blue on the left basically is the fact that healthcare workers did not have confidence that PPE would be made available and accessible in places where they work. On the right, you'll see that the gray says that they would have more confidence in terms of when they have to, what they have control over, like the correct use of PPE, donning and doffing of the PPE, which simply means that healthcare workers trusted themselves to learn how to use PPE and use it correctly and wear it and put it on and take it off, but they did not trust the working environment to provide PPE. Now, these numbers, of course, generally speaking, are also relatively low. We would have expected that at the time of the survey, they already knew these areas correctly. And also just to highlight that in general, the correct use of PPE is linked to confidence. The more confident healthcare workers felt, you can see that the risk, self-perceived risk is lower. But when they don't feel confident on the extreme left, their risk perception is much higher. So it's important that healthcare workers feel confident in their knowledge, in their practice, in their confidence of using their PPE items, because then this translates into their risk perception. The final section that I'm speaking to is about the general health and well-being of health workers. And here, just to note that health workers were generally very concerned about the risk of passing infection to their family members. And oftentimes, even though we hear of these stories, this is not something that I would say we pay enough attention to. The risk that a healthcare worker could bring COVID-19 into the home, and someone in the home could be infected. And you can see that the personal risk was actually relatively lower than the risk of the concern they had for family members. And for us, this was interesting and important. And again, you can see that the concern was much higher for nurse practitioners compared to other healthcare professionals. And this was statistically significant. At least 2 in 5 healthcare nurse practitioners were very concerned about the risk of COVID-19. And also just to note that by professional category also, the distress, the issue of distress, this was an important finding from the work that we've done, that there was high levels of distress among healthcare workers across the different professional groups and across different sectors. But I just want to highlight 2 things that are important here. For the nurses, the severe distress, which we expect that for any healthcare worker, it should be 0. It was about 25%. 1 in 4 nurse practitioners were experiencing severe psychological distress. And you can see also that compared to the other sectors, there was more distress for healthcare workers working in the public sector. Again, close to 1 in 4. I want to note that this distress, you could see it across different professional groups. But just to note here that for the nurses, this was much higher compared to the other professional groups. And also in terms of well-being, you will note here that for nurse practitioners, they had 44.4% of them who had poor health, so to speak, compared to other professional groups. For example, if you look at other healthcare professionals, it was only about 25%. Now, generally, we know this, that because of the nature of the health workforce amongst nurses, you may expect that they would have poorer health relative to other categories. But it's also being demonstrated in the survey. What is of note to realize here is that when healthcare workers are having poorer health, as you can see on the left, they also experience high levels of distress. And if they are having good health, they experience relatively lower levels of distress. So there is an association between the well-being of healthcare workers and their levels of distress. Just to wrap up, I want to mention some of the recommendations that we have identified emerging directly out of this study. And they cover this sort of broad areas of the well-being of healthcare professionals, their surveillance, their communication strategy, workplace support, community support, infection control and PPE, and in-service training. As Prof. Reddy mentioned earlier, we struggle to find information on healthcare workers. It should not be that in South Africa that we do not have a central database for information on healthcare workers. This needs to be corrected as soon as possible. And also, we need to make sure that we hear the voices of the healthcare workers, because the interventions that we need to put in place need to be informed directly by them. It is useful when we have this survey and we are able to present it to the ministers, we are able to present it to the NCCC, because now they can take the information and use it to inform their interventions in terms of what areas they need to address for intervention. But currently, this information is not readily available, and this needs to be corrected. Likewise, we struggle to identify, in terms of occupational health and safety of healthcare workers, what does that responsibility, who does that responsibility sit with? Is it sitting with the government itself, the Department of Health? But at the same time, the department is an employer, but also may be running occupational health and safety. That needs to be clarified so that there is no perverse incentive. And if it's government, will government oversee the health and well-being of healthcare workers in the private sector as well as in the non-governmental sector? These things of custodianships need to be addressed, and this is where the councils also could play an important role, not only to look at what health workers may be doing wrong, but to start thinking about how are they supported to work effectively. Now, we've seen with the pandemic that the sources of information and the type of information healthcare workers get on the ground is important in terms of how they engage with their patients. But we have found that there isn't a clear communication strategy to make sure that information can be relayed to healthcare workers through a reliable source in a way that is timely, that is regular, that is factual, and is not sensationalized. And to the idea of relying on social media and news websites can introduce the problem of fake news and so forth that healthcare workers can start working with. It's important that this framework for communication is designed and information is synthesized very quickly and disseminated through reliable sources, including NDOH, but it must go to all sectors of healthcare workers. Likewise, training needs to make sure that it's done timely. All healthcare workers, by the time the pandemic took hold, training was supposed to have been done. And it also needs to be comprehensive to make sure that it covers the broad scope of the different areas that healthcare workers have to work with, including screening, including recovery, including all the different areas. But also, we mustn't just focus on one type of healthcare professionals like medical professionals or medical doctors. We must also make sure that all healthcare workers are trained, and they're trained to a point where they have confidence in their practice. And building confidence is something that has to be intentional and aimed at broad healthcare teams rather than targeted at specific professional categories. And also, we need to make sure that in terms of safety, this is done in a workplace environment. A lot of the talk in the media has been, and in the public has been about PPE itself, but there are so many other factors around environmental controls that we don't talk about. And these things need to be articulated very clearly and put in place. And hospital and facility managers need to be held accountable in making sure that these things are in place. And also, health workers need to have confidence in their facilities and facility managers making these things important. Likewise, support for the more generally for healthcare system, we need to make sure that the public is able to support this by making sure that they don't engage in behaviors that risk putting a lot of pressure on the health system and therefore the healthcare workers. And when there's pressure on them, then the risk also increases. And also in terms of just training, we've mentioned that it needs to be around PPE, it needs to be comprehensive and practice. You know, for PPE, we need to make sure that health workers are using the right PPE in the right places at the right time. And it's not just a matter of having PPE. And also they need to use it properly and have confidence in how to use it. And a lot of practice is required in donning and doffing and making sure that this becomes a natural pattern of behavior amongst healthcare professionals. And also just to say that for healthcare, protection of healthcare workers in terms of health and well-being needs to be developed and implemented to support healthcare workers so that healthcare workers are looked after. They're not just an instrument to achieve a means, but they themselves can be an end in terms of being looked after, including in terms of making sure that there is core curriculums to support them, including psychosocial components, and including intentional efforts to promote their health and well-being. And this needs to be done in a way that is multidisciplinary. And these mechanisms are important to shield not only the healthcare professionals at risk, but also to shield their family members. And these examples might include things like hosting healthcare workers in certain institutions or buildings, and they don't necessarily have to go home when they are on duty, or rearranging work environments so that the families of healthcare workers are not at risk. I would stop here and thank all the participants in this study and hope that the findings, as we have already shared them with the decision makers and policymakers, can result in actual interventions as we move forward in this pandemic, and all the people that have contributed to this study and promoting it. Chair, thank you very much, and I will hand over back to you.
Thank you very much, Prof. Moshavela, and also thanks a lot also to Professor Reddy for a very informative presentation that colleagues have given, which gives us an overview of what is actually happening among healthcare workers to the extent that they're dealing with the epidemic that we face. Now, I'm going to move on to the next session where our esteemed discussants will be responding to the presentation that my two colleagues have presented. But before I give them an opportunity, I will first introduce our discussants. First one would be Dr. Nhlakanipho Gumede, who is a clinical manager in Edendale Regional Hospital in Pietermaritzburg. He has worked in the public sector for 10 years, worked in primary healthcare setting, district health setting, and regional settings. He has both clinical and administrative experience. He is part of the Edendale Hospital COVID-19 Steering Committee. His passion is on employee wellness and high quality and safety. I'll move on also to introduce Professor Nokuthula Sibiya, who is the Deputy Vice Chancellor, Teaching and Learning at the Durban University of Technology. She has previously served at DUT as an Executive Dean of the Faculty of Health Sciences and Head of Department in Nursing. For recognition for excellent contribution in primary health care, in 2015, she was inaugurated as a Fellow of the Academy of Nursing of South Africa. In August 2018, Professor Sibiya was awarded by the then Department of Science and Technology as the 2018 South African Distinguished Women Scientist in Humanities and social sciences. She has published over 65 peer-reviewed articles and has successfully supervised over 65 postgraduate students. She is an NRF-rated scientist. Our next discussant will be Dr. Khosile Tlhape, who is currently the President of the Health Professions Council of South Africa and Chairperson of the Medical and Dental Board. Dr. Tlhape obtained his MPCHB degree in medicine from the University of KwaZulu-Natal in 1981. In 1988, he completed his FSc degree in ophthalmology at the College of Ophthalmology Medicine, South Africa. In the same year, he obtained his FRCS degree in ophthalmology at the University of Edinburgh. He has held several chairperson and president of South African positions in his career. Our next discussant will be Ms. Sizo Mchunu, who is currently a registrar and CEO of South African Nursing Council. Is a director of nursing education, National Department of Health. From 2015 to 2016, is a deputy registrar at South African Nursing Council. Was a lecturer at University of Zululand for 8 years, and lecturer at St. Mary's College for 10 years. And also we'll have Ms. Veronica Tashin, who is a nursing director, stakeholder management in the Office of the Chief Nursing Officer at the National Department of Health. She is a professional nurse, a midwife, and has a master's degree in health professions education. Who will then be followed by Mr. Simon Hlungwane, who is the president of DINOSA, who holds a BCAT degree, who is on his second term as the president of DINOSA and is currently with the Gauteng Department of Health. Last but not least, he will be followed by Mr. Amos Masango, who is qualified as a pharmacist at the University of the North, which is now University of Limpopo, and continued his studies with MSc in medicine, in pharmacy at Medunsa, which is now University of Limpopo, Medunsa campus. Amos Masondo has worked experience ranging from pharmaceutical manufacturing, public sector, and administration. He spent time in industry as a pharmacist intern, production pharmacist, consumer compounding manager at Bristol Myers Squibb in South Africa. This involved manufacturing pharmaceuticals, consumables, and designing of control system. He established and served as the first head of pharmaceutical services in Mpumalanga province. Before working in the South African Pharmacy Council, he served as a council member and chairperson of practice committee. Amos also has the experience of working as a senior manager, professional affairs, overseeing both pharmacy practice, education, and training matters. He is currently the registrar and CEO of the South African Pharmacy Council. He has served in various capacities in the development of policies and standards on the issues affecting the pharmacy profession in South Africa. Over to you, Dr. Kumede.
Well, I'd like to take this opportunity and thank the opportunity to Prof. Zuma, the chair, but also thank the presenters, Prof. Reddy, for a wonderful preamble of the study, and also Prof. Mashabela, who just told us largely about the surveys that are involved in today's discussion. Well, I am drawing my inspiration from the knowledge of the obvious that if you want the best outcomes possible, we have to be prepared to invest in the people who will be responsible to produce the intended outcomes. And in particular, this survey actually asks relevant questions at the right time. And I'd frankly say that from the experience that I have, it actually does reflect to a larger extent what is actually happening on the ground. And I would like to welcome the survey report in its form. And I see so much value in this type of survey because it talks so much to the implementers, the doers, and mandates the decision makers to respond to the issues that might be identified. And once there's poor communication between those that are implementers and the decision makers, then you will find a very chaotic situation, especially in the times of pandemics when everybody is really unsure. Now, the results of this study are not really something that would shock us so much, but actually it does show what is actually happening every day, and while the healthcare workers actually battle every day. It was quite interesting to actually note a few of the things that were produced by sort of like the study in terms of the confidence of the healthcare workers that they have with regards to the managers and the people with authority being able to provide protection for them. I think that one is something that I really would want to explore a little bit further in terms of ensuring that we are able to provide such thing. The most common complaint that we find at our level is actually the lack of proper training for the healthcare workers, but also the lack of appropriate sort of like protective personal clothing. And poor communication prevails, and also the ever-changing strategies actually disturb psychologically the healthcare workers in our midst. And to some extent, healthcare workers have always talked about the need for psychological support, and as always, they would say that they are not okay. But I would like to believe that the timing of the study would have been great if the government would tap into this knowledge earlier in the pandemic to guarantee proper interventions to ensure maximum participation of the healthcare workers in the control of the pandemic itself. And obviously, we all know that health workers want very few things. One, they want to be heard. They want to know that somebody understands and want to respond to their concerns. Two, they want to be protected against being infected and at the risk of their family members being infected as well. Three, they would want to be prepared, to be provided with the relevant information. And information doesn't have to come once, but it's information that needs to come continuously throughout the pandemic to ensure that they are on top of their game. And lastly, they would want to be supported so that we also know that there is actually human limitations in what we're trying to do. Therefore, in summary of all, I see this study as being critical in how we will need to deal with future pandemics as a country as a whole. Thank you, Chair.
Thank you very much, Dr. Kumeda. So we'll move straight to Professor Bia.
Thank you. Thank you so much, Chairperson. Good afternoon, colleagues. My sincere appreciation to Professor Reddy and Professor Mashabela for sharing the findings of the study that they conducted on COVID-19 pandemic. Chair, there are two issues that I would like to raise based on the presentation that was done by the two speakers. The first one is on addressing the shortage of healthcare workers. Colleagues, it's a fact that we need to double, if not triple, the masses of the healthcare workers that we produce as training institutions. Fortunately, I come from one of the training institutions in the province. You would recall, colleagues, that when the minister made a pronouncement or an announcement in May with regards to the students that would return to campus under level 3 of lockdown, he did mention amongst the students, he mentioned the students who require clinical training. And of course, those are students in health sciences faculty. But then the question is, as higher education institutions, were we ready to receive the students? The facilities where we place these students, were they ready to receive our students? Then the answer is no. Because in order for us to be able to produce the kind of graduates, the kind of healthcare workers that would be able to deal with such conditions as COVID-19, we need students who have been exposed in clinical facilities so as to gain the experience and the expertise. And maybe the second question, Chairperson, that I would like to touch on is training. I know Dr. Nhlanhla has spoken about training of healthcare workers. It was quite concerning for me when Dr. Mashabela was presenting the findings that some of the healthcare workers displayed lack of knowledge of the COVID pandemic. And this requires us as the training institutions to revisit our curriculum so as to ensure that we produce the kind of the graduates that will be able to deal or that will be able to manage this COVID-19. We often talk about flexible curriculum. So it's high time for us to show that high flexibility of the curriculum so that we, at the end, we produce the kind of the graduates of the healthcare graduates or the healthcare workers graduates that will be able to assist in managing this pandemic. Thank you, Chairperson.
Thank you so much, Prof. Sibia, for touching on those very important topical issues that concern the public health space. Now, I'll move on now to Dr. Letlapa.
Thank you, Chair. And I'd like to thank the presenters and the opportunity given to the HPCSA to come up with a perspective. 2 minutes is not much time, but there have been issues about access to knowledge and the knowledge of the people in the rural community, and that people access websites. And I think part of the issue that we should not discount is the issue of bandwidth, because all these issues depend on being able to have a stable access to the internet, to be able to access these issues and to be part of training programs. So part of the issue should be about appropriate infrastructure in remote areas, so that even health professionals that are in the remote areas are able to connect, and that might contribute to the disparity. The second issue I'd like to comment about is the issue of risk perception vis-a-vis the real exposure risk, and the fact that nurses seem to be more aware. My concern as a medical doctor is the cavalier attitude of medical practitioners. Are they taking things too lightly? Are they infecting their families at home? Are we not exposed? I mean, in Gauteng, we've just buried 9 colleagues in the last week in relation to COVID. Are we reckless? Are we doing the right thing? When you look around and you see DGs of health in provinces having seminars, everybody in the room is masked. The doctor is speaking. He's got no mask on his face. He's got no mask on his neck. You get the behavior like we think we're invincible. When you see the things that are out there, there's no social distancing from the healthcare professionals that are talking to the public about social distancing. So the issue of risk perception becomes a real issue, because people are monkey see, monkey do. If you're talking seriously, but you don't act seriously, it all becomes a joke. Then the issue of appropriate PPE, who is responsible. And I think what has been lacking is clear communication of what is appropriate at what level, and ensuring that the health facilities are zoned in terms of that, so that everybody is clear. Because sometimes you don't have a clear message to the health workforce, and people are asking for what is not appropriate at the level where they are working, but that has not been clearly communicated. There aren't enough engagements in the workplace to ensure that people have the knowledge. Now, when we have a fire as an emergency, you don't get the drill during the fire. There are fire drills during the year. On health emergencies, there are no drills. And we're hoping that without drills, when the real thing occurs, we'll be ready to deal with it properly. So it's something to be factored in. Work arrangements. Globally, work arrangements have been made around COVID, where it's been known 7 days on, 7 days off, people should be in a secure location so that they do not take the infections home. Where is that in our planning? Where is that communication? Is it left to the health workers to do what they want? The fact that we have healthcare professionals and the key resource is nurses that have to go into COVID areas, and coming from a COVID area, you go into crowded public transport to get home. What type of response is that from the nation? So all these issues require engagement. I've been called by many practitioners who are concerned about indemnity. If I'm going to work out of scope, am I protected? There's no question about how you indemnify people when you say it's an emergency and they have to do things maybe out of scope in the interest of saving the profession. And there is no comment around that issue. And lastly, part of what we should be concerned about is that when we're assessing the knowledge and when we're focusing on the curative side, when the way to deal with this pandemic is on the preventative side. So I would have been interested to see assessment of knowledge of what the healthcare professional thinks their role is in educating the public and on prevention and curbing the spread of the epidemic. It was heartening to note the questions about people not having sufficient knowledge about contracting it from surfaces. But more importantly, what is lacking is our response, is the response of a sick system that responds to sickness. And it highlights the fact that on the preventative side, whether it's education or even in our response to the pandemic, it is pathetic, to say the least. I thank you, Chair.
Thank you so much, Dr. Lehlape, for raising those important issues that indeed affect our public health system. And this epidemic, I think, if it has done anything, it has really exposed us as a nation in terms of the weaknesses in how we are, protected from these kind of the epidemics, which I really will be with us for many, many years to come. So I will move on now to Ms. Mkhunu to give her response.
Good afternoon, everybody. Thank you very much, Chairperson, and I would like to say we appreciate the invitation. We also appreciate the presentation that's been given, and we appreciate the work that has gone into the study. Like Dr. Lehlape said, maybe 2 minutes is not enough. You know, one thing, there are about 4 things that I would like to raise very, very briefly. One of them is the, I think Prof. Mushabela spoke about it. You know, the correlation between the low confidence, and specifically, I think amongst nurses, and the level of training and also the level of knowledge regarding the disease. Now, when I was looking at that, even prior to him speaking, I was asking myself a lot of questions and saying, is it the adequacy or relevance or both of training that has been received that would cause low confidence despite the training having been given? I was also asking myself the question whether there is a need, you know, to intensify EAP programs and debriefing sessions in order to try and limit or eliminate the stress and anxieties and fears that are expressed by nurses, because they are very real. But the third thing that I was asking myself was whether this had to do at all with the readiness to practice. Is there a match, especially at this time, is there a match in respect of skills and competencies required in an area of deployment, for instance, in critical care units and the program that nurses have undergone, or the category of nurse that is working in that specific area? Because that may have actually quite a lot of influence on the confidence of a nurse. And it's really a pity. I know the study is very involved, but I know that the categories of nurses were not segregated so that we know whether we're talking to professional nurses, specialist nurses, or the other category. The second issue that I would like to point out is, for me, the study has revealed such a lot of important things, but one of them is that it looks like we are not ready to handle gross infectious diseases, if I may say so. And probably this is something that we need to look at in terms of training, in terms of new programs, because these are here to stay. The third issue that troubled me was when I looked at some of the concerns, and some of the healthcare workers were complaining about long shifts. And for me, that actually said something needed to be done there, because a long shift should not, let me put it this way. If a healthcare worker complains about a long shift, maybe we need to look at, should we not have breaks, you know, especially when we're dealing with a stressful condition and stressful situation like this. And if they're complaining about long shifts, should we not go into what Prof. Lehlape was actually suggesting, so that people have got a few days, I'm not going to say how long, he said a week, a few days off and a few days on, so that they can be able to debrief, they can be able to galvanize their energies, so that when they come back, they are feeling a bit better. So for me, those were the issues that I wanted to raise. Thank you very much, Chair.
Thank you so much, Mrs. Mkhuna. I'll move on now to Ms. Tasha.
Thank you very much, Chair. I'd like to say thank you very much and in appreciation for the study and all the work that has been done. And for me, what is very important is that it has really highlighted the importance of data and information going forward in terms of planning. But we need various kinds of data to help our nurses in particular, and I'm talking specifically about nurses now. But it also just says that we've got many more studies that we need to do to be able to come up with information that can be of assistance for us in terms of planning. But as one of the previous speakers has said, is that it's confirmed basically what we know. These are not things that we've not known before, but I think it showed us up in a pretty poor light by virtue of the pandemic that has come. The great concern that I had was specifically related to the training that the nurses received, because as one can see with the results of the study as well, it just means that we should really beef up all of our in-service training and other training, as Ms. Mkhunu has also alluded to, in terms of the training that nurses receive. I was rather enheartened by the fact that NDOH was used quite a bit in terms of information, but that just tells us then that as NDOH we should actually improve our communication and find ways, as was also mentioned, broadband, this thing for the rural areas, and I think that really would be of great significance and great help for all the personnel to actually receive proper and appropriate information. Again here, the psychological distress was really really a bit painful to hear. But it also just means that, a lot of what we were supposed to have done was before this pandemic happened. And it should be happening on a day-to-day basis. There are many, there's a lack of EAP programs specifically geared to nurses. And you find that often access to them might be there, but due to various logistic reasons, they are not able to reach them. So again, here we should find better ways to be able to reach our nurses, to be able to give them the ways to debrief and ways in which to cope with stress. The kind of complaints that I've received now lately has always been that nurses, that what they can't deal with is the fact that they have to stand with the patient when not even his relative is there to assist them, and they carry that with them home, over and above the risk that their families actually receive, but they carry the psychological problems and the psychological stress with them home. And clearly, we all know that it can definitely influence their home life. But this just says that we should have prepared beforehand. The preparation that we are supposed to be doing is so very important. But while we are in this pandemic, it doesn't mean we must just keep on just looking at the curative, but we should also be preparing, because we know that this is here to stay. So we have got a lot of work in preparing and planning as to how are we going to sustain the nursing health workforce to be able to deal with all of the kind of stresses and that they have experienced. That to me is very important. And I think, the changing information and I might say, let me just not say contradicting information, but I mean, when that came with the methods of treatment as well, when we couldn't decide whether it's aerosolized, is it, and what kind of treatment are we giving, and then nurses were given the hydroxychloroquine, and all of those issues can be very confusing to the people who are actually working at the bottom. So that really played a big role as well in perhaps nurses not feeling so confident. It's like what is happening today is not the same in the following month. So maybe, going forward, this should be something that we should learn and take heed of when we are planning for any other hopefully not pandemics, but any large infectious disease as we have them now. Thank you so much, Chair.
Thank you so much, Ms. Tashil, for raising those issues and also responding and highlighting on some of the issues that have been raised. So now I'll move on to Mr. Hlungwane.
Thank you very much, Chair, and much appreciation of the presentation, and thanks to the presenters, Prof. Reddy, as well as I can't remember who presented the other one, but anyway, because of the time, I think the study is giving us, yeah, it was Prof. Mushabe. The study is giving us and confirming indeed exactly what we have been raising. And I must say, some of the areas that it has picked up, we have been raising them as far back as around April. When you were to make an example of the issue of training, we have at that time requested that can we have training that is specific, online training specific for health professionals, not mixed with the public, not mixed with the other support services or support staff within the health. And it was our foresight and the complaints that were coming from the members and the nurses in general. However, I think in our, as it is said, and I agree, we are treating as a country, now that there's a pandemic, we think it's an incident, and we're not approaching public health as a day-to-day well-being of the whole nation. And if we were treating public health as not an incident, we were going to be having, even currently, if you were to check what's happening in the communities, the only people who have been to the communities door to door were doing the screening once off, maybe some around May or around June. Even now, there's none who's going into the communities, whether rural or not, to educate people on how do they prevent themselves from getting the disease currently. So if we were to approach public health in a different way and not as an incident, we are going to have a better way. But the study is highlighting very fundamental issues, the issues of data, which I think is a shortcoming on our side. And if we don't correct it as it is stating, we are going to see ourselves having serious problems. And the other element that I think Prof. Reddy has mentioned was the issue of the State of World Nursing Report, which highlights clear in regard to the kind of thing why we were so exposed is that we were not ready even in terms of the availability of human resource. And we ended up, at the current moment, we are having people who are employed for 3 months, yet we are saying as a country, we are going to be having the COVID-19 for the next 2 years, but we employ people for 3 months, contract and 6 months contract. You can see that our planning is not necessarily informed and assisting. And sometimes when we look into the psychological distress, I think we should not discount the fact that, because it's coming out clear as a way to show us that when you experience somebody dying in your hand, it is very, very distressful. And currently we don't have a system that provides support to people who are working in the health sector. And also the exposure in the long term, it's a problem that is highlighted, and also giving the shortcomings that are coming out from the study itself. Now, the bigger question we must ask ourselves, if this pandemic disappears, are we ready for another pandemic? Because if we can't answer that question, or if we are not even thinking about the question, we will relax. And tomorrow we'll be hit by another health crisis. So we need to prepare as a country, we need to prepare as a nation, but also we need to prepare as health professionals. And for health professionals, the question will come to say, is our curriculum ready for any health disaster? And I think we must do an analysis in that space, and we correct it and make sure that at least we are able to make our curriculums relevant and ready for any health disaster. Otherwise, I fully agree with what has come out, because we can see that it's the issues of transport, the issues of accommodation are the things that we've been raising during that time. And I can tell you that it is a problem when it comes to the issues that we have raised, and we see them coming out in a study. It helps our argument, even for the future. I do hope that it can assist us, because even when you look at the issues of training, I can give an example of a particular institution where they were dealing with TB patients. It was TB MDR. What happened is that the department would have taken a decision to remove MDR patients or TB patients there, and said they were putting COVID-19 patients. The nurses who were made to nurse those patients there, they were told, you will know, you'll apply what you used to apply for TB-MTR. Yet we're dealing with something that is new, although we understand nobody had no information or concrete information. However, there was not even a single brief to the nurses that were working there. So they had to rely on their own on where they scramble information and all that. It then suggests to us that we were not ready in imparting information, little or big, that was available at that particular time. And people ended up having to rely on social media, the news themselves. The fourth industrial revolution, the issue of technology that is taking over everything, including the fake news that is there. We must then tell ourselves, how do we as health professionals ensure that we filter information? We cannot do away and discount the new changes in technology, but how do we fit in the purpose of the technology and make sure that the correct information is provided and we beef up information to assist the professionals that are there. I think we don't have much time, but that's the little input that I can say. We appreciate the research. It's very informative. It confirms what we wanted, and we think we welcome it. We'll definitely use it even for the future. Thank you very much.
Thank you so much, Mr. Shongwane, for your well enlightening words there and information around the challenges that we face in public health as far as the epidemic is concerned. Now I'll move on to Mr. Masango, our last discussant.
Yeah, thank you, Prof. Zuma, Reddy, Mushabela, and the other discussants. The survey is very much welcomed. This should help us as a country in moving forward. If we implement the recommendations as this thing as put together. And I just want to say that, I mean, we have been hearing that, you know, we learn as we go, because no one was, you know, exposed to this pandemic. But like as Mr. Shongwane is saying, I guess that should not be the case. As a country, I think we need to be always prepared, you know, for any kind of this thing, pandemic. I just want to comment on some of the issues here, the knowledge of incubation period, symptoms, and transmission. I think from our side, this is varied. I mean, depending on where the person, for instance, would be working. That is individual versus the corporate pharmacies, and whether pharmacy is public or private, because you find that most of the pharmacies, for instance, if I may, you know, refer to them, some are private, some are this thing, some are public, and then the distribution of information, you know, how they get information is also very much varied, and hence I think when you look at some of the healthcare professionals, I don't know in as far as their participation is concerned. I mean, whether, you know, the survey did actually reach them. I mean, in terms of, you know, the database that you're referring to, that we don't have a central database. So far as the sources of information on COVID is concerned, we as the statutory body, we were trying to give guidelines. Would give e-notes, the circulars, you know, also via social media, sometimes on the interviews and stuff like that. And also when there were documentation, for instance, like guidelines which were circulated at WHO, NDOH, you know, and the like, who would, you know, put them on our website, you know, for accessibility by professionals. Sometimes we would also generate information, you know, to the profession as a regulatory body, you know, giving information to the profession on some of the issues. The issue of training, I must say that the non-formal training, unless by individual workplaces, or self-training from guidelines, training would mostly also depend on an area of employment, e.g., I mean, examples here. Hospitals, like as I'm saying that when pharmacies are in the private distinct sector, and then the training will be very much scattered. It will depend on either if the pharmacy is in the corporate or it's individual. But most of them would then, you know, do self-training as they receive guidelines and information that would be, for instance, forwarding to them. On the issue of the risk perception, persons who were more exposed to working with patients directly would be more concerned about the exposure. And that's how we're actually looking at that. The risk factors for contracting COVID-19, besides what has been mentioned, the age, public transport, comorbidities, I think also the fact that what we got from most pharmacies is the issue of, a person just walking into the pharmacy, for instance, with flu symptoms or requiring flu medication, and stuff like that. And then later on, the pharmacist would then learn that that very same person was actually, turned out to become COVID-19 positive. And so that was also a bit of an issue for the sector of this thing of pharmacy. But just to touch on some of the recommendations, for instance, that were made. The database of healthcare workers sits mostly with regulatory bodies in this country. There has been attempts in the past to establish a central database, but this has not come to fruition yet. The issue of communication strategy for public health emergencies, the successes of this also largely depend on the information hub, but also the availability of the central database. For instance, the Department of Health would mostly ask Pharmacy Council, to distribute information on their this thing. To the registered person with the Pharmacy Council. The in-service training and continuing medical training, this should also cover all sectors. The fact that we still have differentiations in the private and public health sectors makes it difficult for equitable training. And again, like as I'm saying, that we also don't have the central database. Actually makes it even more difficult. Thank you, Professor Zuma.
Thank you very much, Mr. Masango, for that enlightening information again. And now, colleagues, we will move on to a set of questions that we have both online and also on some that we've received separately. And I'm going to throw these questions and colleagues will respond to them accordingly, so we may have to share the questions. The first question that we receive is about in re-imaging the post-COVID-19. What are the educational tools for health workers that should underpin normative aspects of social policy change to preventive and curative practices? Maybe I should move on to the next one. It says, what are the innovative ways to achieve a comprehensive social policy changes in the training and reskilling of health workers as frontline workers that can help in achievable outcomes in question? The next question is on a question based on mental health support for healthcare workers, which is one of the issues that we looked at in the presentation. If any is available and considered, few challenges have an array of mild mental issues ranging from anxiety. Few colleges have array of mild mental issues ranging from anxiety to struggling to sleep. Are there any structures in place or in the near future to help? The fourth question is, how children are experiencing stigma from schools when schools were opened. Is there a protective plan to address on behalf of healthcare workers directed towards schools and specific communities who tend to think how their children pose a threat? The fifth question is there a team tasked to kindly monitor how well we are working under COVID-19 guidelines, for example, the use of PPE and working environment, or availability of PPE and working environment? The last one is there a devised working system to salvage our current nursing staff shortages brought on by COVID-19 related staff shortages, be it ill or increasing headcounts? one extra free day to rest a month, or incentives to boost morale. Currently, we have workers struggling with care for their children, paying nannies double, worried about sick family members, but they are still coming by at 6 a.m. I think this still partially speaks to mental health and other comprehensive or holistic approach to supporting healthcare workers. In quote, I sought out the nation, but nobody sought me out type sentiment that is actually experienced. So those are 6 questions for now, and then we'll move on to the ones that we've received online. Over to you, colleagues.
Okay, so let me start. I would also like Dr. Letlape and Ms. Mchunu, maybe also Ms. Tashel as well, to respond to some of the staff issues and also some of the regulatory issues. But I think in terms of the training issue, in a way, I think that this point that was made by Prof. Sibia on flexible curriculum and training is important. It's the way we do in-service training. I think that for us, what we are finding is that in order to do training, to achieve confidence, you need a different kind of training. I think Dr. Letlape said it well, that you cannot do drills during a fire. You have to do drills beforehand. And somehow I think that we don't have that. We tend to learn on the job. And in the case of public health emergencies, we don't really have the space to do that. We suffer a lot of casualties when we try to do that. And I think also Mr. Tlongwane said that we need to do this longitudinally. So I think we must not just do things once off. We tend to just do things once off and that's enough. We tick a box. We focus on what we are delivering when we're ticking a box. We don't focus on what the education that we deliver achieves in the person who's the recipient. If we can focus on the impact and the benefit for the person who is the beneficiary of the training, that will help us a lot. We know these things, we understand them. So it's this thing about fit for purpose. We have to be intentional in training to make sure that our healthcare workers are fit for purpose. A lot of these things in pre-service training, we do them. But when we get to in-service training, we just assume that people have been trained and they know what they're supposed to do. And it's not fair on the healthcare workers. So we need to really make sure that we are fit for purpose. But the one thing I do want to raise in these questions you're raising is the issue of occupational health and safety. I think that this issue of fragmentation of sectors, where healthcare workers are different are working in different sectors, does not really give us a unified way of providing occupational health and safety for healthcare workers. When we were doing this study, we kept debating, who are we going to? Who do we go to if we want to reach all healthcare workers? Ultimately, we found that the best entry point for reaching all healthcare workers across different sectors was through the councils, through the regulatory bodies. And it then makes sense what I think that Mr. Masango is saying, that actually this issue was discussed in terms of where is the central database. It also then makes sense that if we want to think about who is the referee for healthcare workers, in my view, I think that the regulatory bodies have to play an important role. I've said it during the presentation that we have a situation now where we're expecting the employer to be the same one who is also responsible for ensuring safety of the healthcare workers. There is a perverse incentive there. We need a neutral player in this process. I'm not necessarily saying that by statute that the regulatory bodies need to play that role, but at the moment, for me, I can't really see the best group to actually do this for healthcare workers or the best institutions to do this for healthcare workers, except for regulatory bodies. And I would like to hear from the regulatory bodies in terms of what they are thinking is around this. These issues that have been raised by health workers, we hear a lot from the unions. It cannot be that only people who are represented by certain unions, their voices will be heard. We need a system that will speak on behalf of all healthcare workers, will provide support to all healthcare workers. Something needs to happen there. even if maybe there's a different way of constituting it. Let me stop there. Thank you very much.
Thanks, Prof. Mashabela. Well, firstly, I want to thank all the participants, and I've seen the questions in the chat box, and I really want to thank the discussants, because I think they picked on the various aspects of the data and responded directly to it. Also in the chat box, I see that several people are putting their hands up, and Chair, you'll have to explain that unfortunately that mechanism, I think, is not available in this kind of conference, but we will find a way to respond. So yes, I heard the 6 questions, and I think Professor Mashabela did an excellent job to respond to them. I would like to place a slightly different angle, and that angle is one of research. Colleagues, what we've done here is the HSRC is a social science organization, and Professor Zuma is the head of a division which is called Human Capabilities. And we had to make some hard decisions about how we as a research organization were going to respond. And one of the target groups that we selected were healthcare workers. And obviously we did the right thing from what we're hearing. And when we started thinking about how do we do this nationally, we encountered several roadblocks. And I think several of the roadblocks were clearly articulated by all the discussants and Professor Mashabela just now. I see the unions, my heart goes out to the families of all the health workers that have gotten infected, that have passed away, to just hear my dear friend and colleague, Dr. Letlapa, saying he buried 9 doctors this weekend. It could be any one of them, us, we are surrounded by people in the health fraternity. I talked earlier this morning with Dr. Makanya. She's the Chief Nursing Services Officer from the Department of Health. And she also, mentioned how many nurses had been infected and deaths of family members, multiple traumas, multiple bereavements. But what can we as the HSRC do? We can generate this data, so when the unions talk, they actually speak from an informed base where there's evidence, where there's a lot of evidence. And I think this is our job. Our job is to actually provide you evidence.
I'm here.
This is how the data looks. This is what we're saying. And then for us to find ways to interact with all those organizations that we mentioned. And we're sharing this data with as many organizations as possible. And we will be engaging with those organizations at a one-to-one level as well. And we will share the issues that you've raised, from training to mental health, to health and well-being program development. Perhaps COVID has exposed the fault lines in a way where we have to do things in a systematic way, rather than just from a labor union perspective way, where training has to improve, where we have to do these things concretely. The second thing the HSRC can do is that we can do a second wave, a second survey. We did this at the beginning. One of our colleagues said, well, the data hasn't shown us anything new. Well, if we didn't do it, we wouldn't have had this evidence. And at least we have a baseline, a nationally representative benchmarked baseline on healthcare professionals in South Africa. A second survey will tell us what happened in the in-between period, and a third survey where we can phrase the question such as, okay, we learned this in survey 1 and survey 2. What interventions were put in place by which organizations, and how were they done? I know I'm not responding directly to some of the frustrations expressed, but I can only respond from the HSRC's perspective, and that's a research organization. Thank you, Chair.
Thank you, Prof. Reddy. Thank you so much for your responses. I don't know if any of my discussants, colleagues would want to respond to some of the questions that have been raised before we go to the other questions online.
I'd like to respond to some of the things that have been raised. I think one of the things that we have to contend with, the elephant in the room, is that we've got a system failure. And we need to have a national health system so that all of us can work from the same page and that will create an environment of less confusion to society. We're going to begin to seriously talk about depoliticizing health, deprovincialization, so that we can become effective and be able to speak from one voice and put the resources where we need them on the implementation side. Thirdly, we need to professionalize prevention of disease and promotion of health. Right now, that is not professionalized. So it's not done by the professionals. So we don't create incentives for health professionals to take time to educate the public on these matters, to go into public areas to educate on these matters. If you look at what we've done with this pandemic, we had community health workers. They went in when we were tracking and tracing, and there's been no follow-up in terms of messaging, in terms of prevention messages, and there's been no professionalization. It should have been a team that is going out there with community health workers backed by the professionals of different categories, psychologists, professional nurses, medical practitioners, occupational health specialists, etc. And lastly, we need to ensure that there's clear role definition. What the Department of Health does is important, but it can't be the policymaker, the policeman, and the service provider, because they can't self-police. So that there's clear role definition. And I hope these are lessons that we'll take forward as we try and reimagine our healthcare system. So you can't be player and referee. There has to be proper role definition. We need to have a civil service structure that can be held accountable for the work conditions of civil servants and for the delivery of services to the profession. So that it is not a duality for the Ministry of Health, so that we avoid the confusion and we create an accountable system so that all of us can deliver on what is appropriate for us. And I think, sadly, the regulators have been left aside on this issue. There's a lot that the regulators would have contributed in terms of training, dissemination of information, assuring practitioners, and working together with the relevant authorities for a safer working environment. Thank you, Chair.
Thank you very much, Dr. Clearly, other agencies such as the Office of Health Standard Compliance will have quite a lot of work to do in these areas. Any one of my colleagues, Prof. Sibia?
Yes,
Dr. Kumete?
Yes, Chair.
Chair, I would like to respond on the two issues that were raised as part of the Q&A. The first question was on stigma from school kids. I know that the study that was presented by our colleagues focused mainly on healthcare workers. It did not address issues related to basic education. But as a primary healthcare nurse at heart, I am an advocate for school health nurses. I think along the way, we lost this cadre of healthcare workers. If ever we had these cadre of workers, they would have played a very important role in visiting the schools to assist in allaying the anxieties of these poor kids who are now told not to hug friends, who are told not to sit closely to their friends, who are told to go to school and put on the mask from 7 until 2 o'clock. So I think the Department of Health or the training institutions would need to revisit and look at reviving the role of the school health nurses. And then the second one that I would like to deal with, it's the question on salvaging the nursing staff shortage. I'm happy that my CEO registrar for South African Nursing Council is here, and she will bear me out that we have a large pool of private nursing schools that have produced masses of nurses who are currently unemployed. So I think this is the right time now for the department at provincial level, at national level, to provide opportunities and provide job opportunities to these nurses who were trained years ago. I am aware that the private nursing associations are having conversations with provincial Department of Health so that these nurses are given the opportunities to be employed so as to play a very important role during this time of COVID-19 pandemic. Thank you, Chair.
Thank you so much, Prof. Sibia. Dr. Kumeri?
Yes, thank you, Chair, Professor. I would like to weigh in on maybe particularly one issue about the psychological support for healthcare workers during the times of pandemic. And I've been hearing a lot of people talking about, what we need to do during this time, especially to healthcare workers. And part of the things that are being mentioned particularly are the issues surrounding debriefing. And there has been quite a few papers that have been published around the issue of what type of intervention psychologically and the timing thereof that you provide to people during a pandemic. And such cases involve, for instance, when you talk about debriefing, do you talk about debriefing when we see that the cases are coming down, or do we talk about debriefing at the end of the pandemic, or we want to tackle debriefing during the chaos episode where everybody is up and down? Are we then not going to get the unintended outcomes of that intervention per se? I think that what is critical in this case is that we need to really define what type of psychological support and counseling, if there is any, that we need to provide. Simple issues as advising what to do during the pandemic might as well form part of the issues that are critical in terms of ensuring that the psychology of the healthcare workers are actually in the right space. But I think that there is still more that needs to be explored in terms of ensuring that we really define, and put it down exactly what type of psychological support do we want to give to healthcare workers during the peak season of actually the pandemic itself. I think that is very critical, Chair. Thank you.
Thank you so much, Dr. Kumede. Mrs. Omkono wants to say something.
Yes, thank you very much, Chairperson. I wanted to have just one word on the central database for health information. And I would just like to say, maybe it's time we admit that there has been reciprocal failure in co-supporting each other. The failure may have come from some, if not all, statutory bodies. And I'm saying some because I know the South African Nursing Council has not probably provided the information the way it should have provided it. First of all, I'm saying this because if we have to assist the National Department of Health in relation to this, we have to be able to segregate between practicing and non-practicing nurses. I know that some of the regulatory bodies may have succeeded in doing this. Then the South African Nursing Council is not able, from our register, we are not able to tell who's registered to practice and who's registered just to stay in the register for whatever reason. Because for some reason we still have even nurses that are working outside the country in our register. So that is something that we really need to work on, because you may see the numbers and the numbers do not actually speak to people in practice. But secondly, we also have to look at which we have not distilled. I don't know whether other health professional councils have done it. We have not been able to say, even amongst those that are working as nurses, who's actually working in practice, who's working in management, who's working at an educational institution. For instance, we've got critical nurses that in our register appear as critical nurses, but when you drill down and you're looking for nurses in service, you find them not in clinical service, but you'll find them at universities or colleges and so on. So that kind of cleaning the data really lies with the statutory body in order to assist the department. And I actually saw that the other issue I think I would like to raise is from the other side, which is why I said there's reciprocal failures. the department, for instance, this is not blaming, it's just putting it out there. The department, for instance, has got a PESAL system, and I want to believe that if it can also be clean, the department would be able to have information. For instance, during the beginning of the crisis, you get requests for information, same information from that source and from that source, which actually does say that even the liquor that we have got even on the website of statutory health councils is not being utilized, and people start realizing the value of whatever is there at the time of a crisis. The second point, which I think Professor Sibia has just touched on slightly, I think maybe it's time we have a proper streamlined way of determining who tells what kind of, for instance, what kind of nurse we need to train, what kind of nurse specialist do we need to train in accordance with the needs. Because if you go to our register, for instance, and you check the number of critical care nurses, you are going to find that there are very few. But you go to community health nurse, you go to whatever, and then the numbers are huge. Now, that doesn't begin to speak to the needs of the country, and this is actually showing very, very clearly at the moment. So on the issue of training, there may have to come a time when I am not the owner of the higher or educational institution, and I determine, because I am a community health nurse, that I'm going to train this person, instead of maybe the custodians of service saying this is what we need in service, and therefore you are going to be training this kind of nurse, and you are going to be training this kind of a specialist nurse or a specialist midwife. Thank you, Chair.
Thank you so much, Ms. Mkono. Prof. Reddy, whilst Khomotso is getting ready, maybe you can respond to a question on a survey in the USA found that healthcare workers has heightened anxiety and stress because of the fear of contracting COVID-19 and also losing their colleagues. Is this something that the study picked up? If so, what were the triggering points of anxiety and what are the solutions to lower their anxiety levels?
Thank you, Chair, and thank you for a very, very insightful question. Well, this survey was done when there was worldwide fear about COVID, and nobody really honestly knew the details of how this virus was going to behave and what it was going to behave. And that is reflected in the slides on distress and well-being. And we saw that that nurses were very distressed, and one of the determinants of was the fact that they could take infection home. Okay, so in that sense, yes. And the fear and the issue of losing colleagues, we did not ask that question directly, but in the second survey we can go into that further in depth. What are the solutions? The solutions, I think, have been dealt with to an extent here. Focused training, targeted, sensitive training, training that's intentional with practice, making sure that people are prepared. Because if people are well prepared and well trained, they can protect themselves to the best of their knowledge and their ability. If they're uninformed and confused, as Dr. Letlape indicated earlier on, it's very difficult for them to know which mask is going to protect me in which situation. So I don't think we'll be able to take those fears and stigmas away completely, but if they're riding at 70%, what we will be able to do is to minimize that to about 30 to 40%. And this thing of continual support, of continual clinical audit and debrief, that Dr. Gumede spoke about as well. So I think there are small things that we can do that are not that expensive to do, but are critical for the health and well-being of all healthcare workers. I think we can work on that. And I find this session really, really insightful. The discussants and the contributions and the questions are actually made this data alive, in my opinion. Thank you, Chair.
Sure, thank you very much, Prof. Reddy. So we've got few questions online that I'll urge my panelists here. One of them says, can Prof. Mushabela explain further how the health professional regulators can play a role as recommended? The other question is, the flux in confirmed information has been a significant challenge for general public and many professionals. The resulting mistrust has impaired the likelihood that people will accept new information as science uncovers it. How do we deal with this? That's from Goodman Sibeko from UCT.
Thank you so much, Chair. I really think that the discussions that we've had from the councils, they are the ones that, this is the contribution that I think that the councils could play in playing a referee and helping to get the government, both as the custodian, but also as an employer, to be able to pay attention to these needs of healthcare workers, but also making sure that the needs are directed across different sectors. But as I said, I think that if there is another way of making sure that this can be corrected, it will be wonderful to make sure that we have a unit. You know, I attended another session about medical specialists where the same challenge of finding information was identified. And also the question of human resource planning that happens only every 5 years in terms of that strategy. That actually we need continuity, we need a unit that is looking for human resources of health continuously across sectors. And this point of needs to say, what areas of needs are we going to have in the next 10 years, 20 years, and what trainings do we need to do currently? These things are really important, and I think that we just need to make sure that we attend to them. But I do think that our regulators can assist with this. In terms of the flux of information, really this was attended to by our discussants to say that we constantly get new information and a lot of uncertainty, and we need to fix this. We need to make sure that there's clear communication to make sure that people are not confused on the ground. I think that is clear.
Thank you so much, Prof. Mushabela. I see Mr. Hlungwane wants to say something before we move on to wrapping up and closure, colleagues.
Thank you very much, Chair. In a question that was asked regarding the anxiety and increased anxiety during the COVID-19, I must say that from the complaints and the information that we have, because we also have a war room where we collect information that comes on daily basis directly from those who are in the front line and in the cold phase. I must say a lot of critical care nurses, often they would complain that what creates more of their fears is that sometimes they nurse their own colleagues, and if a colleagues die under your care, what comes to their minds is the fear that, am I going to be next, or when am I going to be next? So it creates that fear. Moreover, on the fact that there isn't even support, and also the fact that if they were to get it, they will definitely give it to their other colleagues who are well, and over and above that, they would give it even to people that they share transport with and their families. So for us, I know that in the research it did not come out, but it's one of the elements that I think as and when the study is carried out even throughout, or even further than that, another study is being carried out. It's an element that can be explored. But I think overall, if we are as a country to make it in any other disaster or health disaster, we definitely have to address all these systemic issues, as Dr. Letlape would have said, because we'll be able to also, from the beginning, say in terms of our human resource planning, we should know how many or what are the ratios of each health professionals do we want to have to be disaster ready as a country, because currently we do not know, and there's no definitive a plan to say we need so many professionals or professional nurses of this particular specialty in order to be ready for this particular disaster and so on. So I think the planning is what should be assisting us going forward. But another comment I have is that if you not only on the issues of, when we look at the system, not only on the issues of human resource, we wouldn't have had a patient, that 67-year-old man who died just last weekend in a makeshift car parking area, if we were ready. And you can look at the time we had from the time we had the first lockdown to prepare, but somebody dies just in August, which is many months when we're into the pandemic, and we're already at the peak. But still, in terms of the infrastructure that we had built was not adequate to respond to the pandemic itself. So if we were to do a proper planning, we should be ready to know that what kind of makeshift infrastructure should we have if the current infrastructure cannot cope. So we should be having some way of standardizing it going forward to know what to do. But I'm just adding that to say those are some of the areas, and the emphasis what Dr. Letlape was saying, so that if we don't have any kinds of planning, the problem is that disaster will wipe us out. And you will see after this pandemic, my suspicion is that we're going to have very less number of health professionals, because some will be dying, but some will definitely retire in fear, because right now, because of the comorbidities and the age factor and the risk that is there currently, most of them will definitely retire because they wouldn't want to be in the employ when the risk is higher. So it means we're going to be having a dwindling number of professionals, particularly in the public health. So we need to have a different way of planning. I just thought I must add that, Chairperson. Thank you very much for the opportunity.
Thank you so much, Mr. Hlungwane. And it's now safe for me, colleagues, to really thank our two institutions, Human Sciences Research Council and University of KwaZulu-Natal, for coming together and conducting such an important survey. And yes, indeed, colleagues, we all have a responsibility to support and protect our healthcare workers, because without them, we don't have a barrier between us and these infectious diseases that are ravaging our country, our continent, and also the global community. So, colleagues, I really want to thank our presenters, thank our discussants, and moreover, to thank you, colleagues, the participants who have been so engaged over these the questions that we've been asking, which are really thought-provoking. And indeed, colleagues, we'll have more of these surveys being conducted, as my colleagues have indicated. So we'll keep you informed about the next time that we present these surveys. I want to really thank you so much. And then the webinar that we had has come to an official close now. Have a good evening, and also stay safe and protected, colleagues. Thank you very much.